It's my pleasure to invite Dr. Muna Bhende to deepen our understanding on cracking the code of diabetic retinopathy, the sugar stain.
Yeah, good morning, everyone. This is not exactly an exam talk, but I hope to interest you and make you understand why diabetic retinopathy happens and how we tackle this fancy topic. I couldn't understand it, so I just used it as my first slide. Diabetes affects every part of the eye, and it starts from the cornea, goes right up to the optic nerve. And diabetic retinopathy is probably the most studied and well understood condition where you have a direct association with diabetes. There are conditions where it's a known risk factor. There are conditions where it is a possible risk factor. And there are also conditions where you would think it's diabetic retinopathy, but it's not. And these are the mimicking conditions. Now, diabetic retinopathy, as I mentioned, is probably the best known and most studied ocular complication of diabetes. And this is a very complicated slide, but what is important for you to know is this single factor VEGF and breakdown of the blood retinal barrier. You heard Ramana Kumar in the morning. He very well described the blood retinal barrier, so he's made my life much easier. This ends up with the two complications of diabetic retinopathy that are sight-threatening, that is proliferative diabetic retinopathy and diabetic macular edema. And we always tell patients everything reflects what is in the body. But diabetic retinopathy, the behavior of the retinal capillaries practically mimics what is happening in the glomerular capillaries, as opposed to the arteries. Which is why you see when a patient has diabetic retinopathy, very often they have diabetic nephropathy and vice versa. And that's something we always ask our patients. And these are the various changes that can occur in diabetic retinopathy. And you realize most of them exactly mimic what happens in the glomerular capillaries. And then you have conditions like the main thing is the loss of pericytes. This is a normal structure. Here you see the retinal vessel with pericytes over it. You have loss of pericytes. What happens when you lose pericytes? You have leakage of blood, you have hemorrhages here. When there is endothelial damage, you know that endothelium forms one of the blood retinal barriers, so you have leakage of fluid and you get exudates. And when you have leukostasis, you have occlusion, and occlusion causes ischemia, ischemia causes neovascularization. And there are various factors which promote diabetic macular edema and proliferative diabetic retinopathy, both inflammatory and angiogenic. And based on the balance between the two, you get your different manifestations. And this is, as I mentioned in the morning, everything has to be in order for the retina to function well and for you to see well. Here you see the perfect structure of all the retinal cells. Every layer is intact and synchronous. But when you have disturbance of the blood retinal barrier, when you have disturbance of the structure, everything goes wrong. The anatomy is distorted because of alterations in the vasculature and new vessel formation. And we all know when photoreceptors are misaligned due to whatever reason, vision is lost. So patient can present to you either with normal vision. We all know you can have severe proliferative changes with a 6/6 vision, or you can have a little macular edema with no background changes and the patient having poor vision. So it all depends on where the pathology lies. So what are the risk factors for a person to develop diabetic retinopathy? There are modifiable risk factors and non-modifiable risk factors. Obviously, what is non-modifiable is the duration of disease, the type of disease, pregnancy and puberty. This is something you cannot change. But what we can change is hyperglycemia, hypertension, and other associated conditions that assume importance when you see a patient not responding or you find the findings a little out of proportion to their diabetic status. And I would probably go one step further when we look at medications. Probably the newer anti-diabetic medications probably have a role either worsening or improving diabetic retinopathy, but they are less well understood, so I haven't mentioned them here. Now, this is something you all need to know. one of the things, the classification of diabetic retinopathy, and now we follow the international classification of diabetic retinopathy, where there is mild non-proliferative diabetic retinopathy. Even one microaneurysm is sufficient to call it a mild retinopathy. You have moderate retinopathy, where you have anything more than a single microaneurysm, and you also have hemorrhages, exudates. And then you have high risk or severe non-proliferative diabetic retinopathy. A common question, favorite question, is the 4-to-1 rule. 4 means 4 quadrants, 2 means venous beading, and 1 is IRMA in at least 1 quadrant. And then, of course, you have proliferative diabetic retinopathy. Now, diabetic macular edema, with the advent of anti-VEGF injections, most of our treatment is based on OCT. So you have these newer classifications when there is no diabetic macular edema, and there is non-center involving, and there is center involving diabetic macular edema. And I'll just show you the images. Now, generally, it goes by stages. The stages may be exaggerated due to various other influencing factors, especially rapid reduction of blood sugar. With some of the newer medications, we see a worsening of diabetic retinopathy with drugs like Ozempic, because there is a sudden control of diabetes, and then you see everything getting exaggerated. Now, why do we get hard exudates? They basically breakdown of the blood-retinal barrier, and you have leakage of serum proteins, lipids, and proteins from the vessels. And the hard exudates occur when the fluid gets absorbed and just the lipids are left behind. They are yellow and waxy. And one thing, they're not seen on fluorescein angiogram. That is because of the difference in the use of the filters. So you see these typical hard exudates, and because they leak from the abnormal vessels, you see these microaneurysms always at the center. That is why we call them sursinates. And then venous loops or beading, they are a response to ischemia. The vessels dilate in response to ischemia, and they are always seen in areas of non-perfusion. Here you see this fluorescein angiogram showing non-perfusion here in the dilated vessels. And these are the most significant predictors for projection to proliferative diabetic retinopathy. And IRMA, these are intraretinal microvascular abnormalities believed to be either dilation of pre-existing capillaries or intraretinal neovascularization, and these are also a significant risk factor for progression to proliferative diabetic retinopathy. Important to know that they do not leak on fluorescein angiogram, but clinically they may mimic new vessels. Here you see IRMA, which is just running between the vessels, whereas new vessels cross the vessel, they run on the surface. So that's how you differentiate. And as I mentioned, proliferative diabetic retinopathy is mainly VEGF driven. Other angiogenic factors can also occur in the setting of blood retinal barrier breakdown and endothelial cell growth. And the hallmark of proliferative diabetic retinopathy is neovascularization. You can have just bare vessels like you see here, and these are most responsive for treatment. Or the patient can present with an extensive degree of fibrosis where treatment may not help much, and treatment in fact can even worsen traction, making the patient a candidate for surgery. High risk PDR, again something you're expected to know because this is definitely an indication for treatment. Large new vessels on the disc, new vessels associated with vitreous hemorrhage either on the disc or elsewhere. Now, whom to screen? We've been always told type 2 diabetes at time of diagnosis, type 1 diabetes 5 years later. No longer. These are not the guidelines anymore. So diabetic retinopathy screening should be done for all people who are known diabetics on treatment whenever they are diagnosed. With a single record of random blood sugar of over 200 milligrams, glycated hemoglobin over 6.5, or gestational diabetes when they first see a medical person. And these are again the guidelines, screening guidelines, important for you to know. The earlier the stage of retinopathy, the wider is the gap. Non-proliferative or mild changes within a year, but as the severity of diabetic retinopathy increases, the frequency of follow-up reduces to even every 1 to 2 months, But in addition, what is important, anything that disturbs the equilibrium of the patient, any sudden change in diabetes can worsen diabetic retinopathy. So then these guidelines would need to change. And how can you screen? Most of us screen in multi-specialty hospitals. It's very easy, but not always practical. You can have models in the community through diabetic retinopathy screening camps. You can do the screening in a laboratory, or you can have a mobile van which takes the camera to the villages. You can have in primary eye care, or you can even use teleophthalmology from primary health centers, where somebody sitting in a tertiary referral center can look at the images and advise accordingly. And of course, you have AI in DR. This is a short talk. So probably where you would use AI was for screening, detecting sight-threatening diabetic retinopathy, classifying DME, and probably predicting treatment response. Now, why image a patient? This is a patient who looks like just a mild diabetic retinopathy. He's come for cataract surgery. You see there are a few hemorrhages, probably classify him as moderate diabetic retinopathy, but look carefully, there's something on the disc, and you get a fluorescein angiogram and you see there's profuse neovascularization on the disc and elsewhere and extensive ischemia. Here there's non-perfusion, and typically the vessels in the area of non-perfusion stain. You have a workshop on FFA later today, so I'm not going to tell you the details. And this is the other eye. You see there is a little asymmetry of the retinopathy. There's profuse leakage from neovascles on the disc in the right eye, but nothing in the left. Wide field fluorescein angiogram has its benefits because we now know that diabetes need not always involve the posterior pole of the eye, it can involve the periphery as well. This is a patient with predominantly peripheral diabetic retinopathy. Other parameters for evaluation include OCT, where you have quantitative measurements but also qualitative features. Like here you have macular edema that is minimal, and then you see on follow-up it is significantly increased. We also have biomarkers that tell you how the outcome may be. These are typical features on OCT. You have a cystoid edema or spongy edema. You can have a neurosensory detachment. Here you see the cysts in the inner nuclear and the outer plexiform layer. And then OCT is also important to classify diabetic macular edema between non-center involved DME and center involved DME. Here the center is the central 1 millimeter subfield. Again, why do you image this patient? This is a patient, again, come for cataract surgery, probably mild to moderate NPDR, well-controlled diabetic. Here I did an OCT angiography, which is non-invasive. There is no need for treatment, but it shows that there's significant ischemia, especially nasal to the optic disc. So it's important to center your image on the optic disc. This patient is at risk for developing proliferative changes in future. And then you have wide field swept source OCT angiograms, which give you a picture that is almost as good as a fluorescein angiogram, though it doesn't show you leakage. Various biomarkers which tell you how you may need to treat the patient, important neurosensory detachment, you have cystoid spaces. Here you have these pillars or schisis, and you have hyperreflectivity within the retinal cysts. So each of them has their own significance as far as you treat. Now this is a patient who has circinates temporal to the macula, relatively good vision. You have microaneurysms leaking, and you have macular edema just off center. So this is a patient you can treat with laser photocoagulation, whereas this patient has more severe edema. But if you look at it, there are these pillar-like schitic cavities. The retinal layers are not well seen on OCT. This patient has a poor visual outcome. And if you look at this patient, you see a large neurosensory detachment. Sometimes these are indications for steroid treatment, and you see just 1 month after steroids, the edema reduces. This patient has vitreomacular traction, and this is what may prevent the macula from settling after anti-VEGF injections. This is a negative biomarker which you need to keep in mind. So how do you treat diabetic macular edema? This is how the normal retina starts, and when the vascular changes occur, this is the beginning and ends up with a lot of fluid collection. So as I mentioned, all your treatments are trying to re-establish the normal anatomy of the eye and thereby improve vision. So this is just a schematic which tells you if the patient has diabetic macular edema, depending on how much edema you have, mild to moderate, depending on the visual acuity. If the patient has relatively good vision, you may choose to observe or do laser photocoagulation, but if it's center involving, then you may need to give anti-VEGF drugs. And as I mentioned, anti-VEGF drugs aim to restore the normal anatomy and stop the leakage. So when do you use laser photocoagulation? You still need to know the ETDRS criteria. When the edema is non-center involving, you can use laser photocoagulation. It's one time and has a long-lasting benefit. Whereas if there is center involving macular edema, if there's no visual loss, you can just observe the patient. If there is visual loss, then you treat the patient. And depending on the vision, there are various trials which have shown that there may be a change in the outcome. So if there's no visual loss, you can observe the patient. If there's visual loss, you treat the patient. If the visual loss is more, if the vision is poor, aflibercept may be better in the first year, but there is no change in the second year. But if the vision is good, any of the anti-VEGFs work as well. So these are the Indian guidelines, which is probably good for you all to know how we treat them. Basically, it's an expansion of what I showed earlier. You can use steroids. Basically, you stop it. You use steroids if patient cannot maintain follow-up visits. If systemically patient has a cardiac problem or severe systemic problem, you don't want to use anti-VEGF injections. Or patients who are pseudophakic or need cataract surgery, maybe in eyes post-vitrectomy. Laser is still a mainstay in the Indian population. The reason being follow-up is an issue, finances are an issue. Laser is definitely cheaper, but it requires somebody skilled to do it. So to manage it, you need to know your patient first, not only the macula or the OCT, what is the vision, how much is the systemic complications which could influence the outcome. Do your appropriate investigations and then treat the DME as per available evidence. Now, as far as proliferative changes are concerned, PRP is the gold standard of treatment, whatever anyone tells you. Definitely in India, where people cannot come every month for follow-up. You can add anti-VEGFs if there is associated macular edema. There are various studies which tell you, yes, PRP works as well. Anti-VEGFs work as well. But remember, that's an injection every month or every 2 months, which the patient has to come and spend much more than they would on a single PRP. And most important, everything going well, macular edema has gone away. You see there's reversal of the DRSS, which is what everyone advertises. And then the patient comes to you with a few months later, severe rebound and now a severe proliferative change. So it temporarily dampens it. It does not treat it forever, which is why for us PRP is still important. But if you have macular edema, then definitely a combination of anti-VEGF with PRP is helpful. I'm not showing any videos for paucity of time, but these are the indications for surgery for diabetic retinopathy. The traditional ones that haven't changed since I was a postgraduate are non-clearing vitreous hemorrhage, tractional detachment involving the macula, and combined detachments. But what are newer ones with our better understanding of the pathology, newer imaging, safer surgery methods? We have various other indications, including even vitreomacular traction, progressive proliferation, and peripapillary traction. And vitrectomy for PDR, early versus deferred, this is a very old study which tells you that this is the pre-anti-VEGF era. It tells you that in type 1 diabetics, early vitrectomy is definitely beneficial. So this is my last slide. 10 things you need to remember if you are seeing a patient with diabetic retinopathy. You have to remember it's not just the retina. It could be any part of the eye that is affected. There are various retinal complications, either direct effect or indirect effect. Sometimes you see the fundus and then say, oh, is this patient diabetic? Or if you see this patient who says he is diabetic, but you have changes in only one eye, is it something else? So you need to look at both eyes. Why does it occur? You need to know, mainly breakdown of the blood retinal barriers. You have various angiogenic factors, inflammatory factors. Whom does it affect? You now know the modifiable and non-modifiable risk factors, and the modifiable ones are what you need to concentrate on. What are the stages and their manifestations? Always remember that patients can present with normal vision and very severe diabetic retinopathy, and this is where counseling is important. You need to know the screening guidelines. The methods of screening, it can be done in any sitting, including the role of AI. One caution when they say non-mydriatic fundus cameras, there is almost 30% loss of image quality, so chances are that you will miss it. So it's preferable to do a dilated fundus examination. You have various investigations that you can choose to do, and there are various modalities of treatment. I have not spoken on medical management because we very rarely do give medications for this. And then always refer to clinical trials. Thank you so much, and I'm glad you all came to Shankar Nethralaya, and hopefully many of you will be stimulated to practice retina in the future. Thank you.